respected dignitaries, organizing team members, and alumni of SBS University, please accept my warm greetings and best wishes. Thank you, Manish sir and Reena ma'am, for providing this opportunity to speak on this great platform. The topic of my talk is emerging treatment for myofascial trigger points. As we all know, myofascial pain syndrome is one of the many issues that affect the muscular skeletal system, uh, characterized by the presence of active trigger points, pain, stiffness, and spasm having a prevalence rate of more than 85%. And these trigger points are considered to be as hyper irritable contraction nodes that give rise to referred pain, and these taut bands are formed that reproduce the pain when elicited for the stimulation. So in inactivation or elimination of these trigger points by using numerous interventions may relieve chronic myofascial pain also. These trigger points develop in the myofascia and mainly at the center of the muscle belly where the motor end plates enter. These occur within the tight muscle fibers and vary from the size of 2 to 10 millimeter and demonstrate at the different places in any skeletal muscle of the body. Yes, these can be present in babies or children, but do not show any kind of formation of pain syndrome, and directly associated with the myofascial pain syndrome and further causing somatic dysfunction, psychological disturbance, and restriction of daily living. May characterize with pain, presence of tingling sensation, burning sensation, and loss of range of motion also whenever active trigger points are present. So when we talk about the types of trigger points, there are several type of trigger points: central, satellite, active, and the latent one. So whenever a muscle fiber is hit by a trauma or any kind of sustained load or injury, there is formation of a taut band followed by latent myofascial trigger point. So these have the tendency to resolve by itself with the spontaneous recovery, but if persistent load is there with the continuous injury or the stress, these latent myofascial trigger point convert into active myofascial trigger point with the presence of perpetuating factors. These may convert into chronic myofascial trigger points. Now, what causes the development of these trigger points? So, repetitive overuse injury, and by using same body parts in the same way, or carrying or lifting weight due to sedentary lifestyle, using poorly designed furniture, tensing or clenching of the muscles whenever there is mental or emotional stress is there, and even prolonged bed rest or activity may cause the development of trigger points. Some studies are there which say that due to the deficiency of some vitamins or minerals may also cause the development of these trigger points along with the disturbed sleep. Now, let us understand how these myofascial trigger points develop microscopically. First of all, what is myofascia? See, it is the combination of two Latin words. Myo means muscle, and fascia, it is a very thick, very hard covering sheath and a connective tissue surrounding every muscle, bone, blood vessel, every organ, extending from head to toe. So let us understand the trigger points microscopically. So these are there are several hypotheses, but the present working hypothesis is when sarcomere and the motor end plates become overactive for a number of reasons that I have already mentioned earlier, the inflammatory responses start gathering upon and leading to loss of oxygen supply, and further leading to loss of nutrient supply also, and involuntary shortening of muscle fibers are also there. So uh, whenever the muscle fiber stays in the same position for a longer time and gets overloaded also. As you can see in the video, it stimulates the release of acetylcholine. It is not showing it here. Further stimulates the reflux of calcium ion from the sarcoplasmic reticulum, and the presence of these calcium ions allow the muscle contraction repeatedly, further and further contraction, by using that sliding filament theory. And the muscle contraction prolongs at the fiber level and in each sarcomere unit, and the segment which becomes shorter and shorter at one point and longer distally, and stretches the rest of the fibers in the band. Now, these stretched segments of fibers give rise to the increased tension to the taut band, taut band of the fibers. Again, uh, the blood flow restriction in these fibers is also faced, which reduces the oxygenation and enhances the accumulation of the waste products and other inflammatory substances, and which further irritates the trigger point. So now the body responds responds by sending the pain signals which are received by the A delta and C fibers, and subsequently brain also stimulates the decreased movement into these muscles, further tightens the structure also. Now, if we talk about there is less oxygen supply and loss of nutrition supply also. So there is a study which was done in 2018 by using the biopsy method. Biopsies were done, and fibers of trigger point and non-trigger point muscle were taken, and they were sent for the high resolution respirometry. And it was surprised to see the results that though no qualitative difference in the mitochondrial function or alteration in the mitochondrial function was seen in when these both type of biopsy sample were compared. So there might be some other reason for the loss of oxygen, might be the compression of the blood vessel, which is one of its kind of hypothesis also. But mitochondria has no role in less oxygen supply in these myofascial trigger points. So examination is literally very easy. Just by the palpation, we can get whether these trigger points or taut bands are present or not. We can feel like a string of guitar or ropey structure in the shortened muscle at a through the tender spot in the shortened muscle, and feel like a taut band, and stiffness is yes also there when we palpate a hard structure. So, management, if we talk about the trigger point injection and going down the lane of the history, in 1930s, Dr. Hans Lynch used sclerometer that proved that these tender areas in muscle are 50% harder than the surrounding areas. In 1940s, the era of Janet Travel, and later on by followed by the Simons, Janet Travel developed injection therapy for the treatment of these trigger points and called them as the tender points, using the saline and procaine, a general anesthetic, for the injection. Then Travel mapped the trigger points and the manner in which they radiate to the rest of the body. She mapped all the things, and her work came into existence when the president of that time was treated by her injection therapy for his back pain. And 1976, Bonnie Pruden, who was an exercise therapist and physiologist, found that using knuckles and elbow with a sustained pressure give a better result in resolving these trigger points than this injection therapy. So several other medical management are also available, like NSAIDs, analgesics, muscle relaxants, anticonvulsants, tricyclic antidepressants, Botox injections. So many medical management are there. If we talk about the physiotherapeutic management, there are several physical agents available, but what the studies say is ischemic compression therapy has found to be give the best result in resolving such trigger points. Now, posture training and education also matter a lot. Education about the posture and the lifestyle have also played a great role in resolving such kind of myofascial pain syndrome, and yet and yes, for the myofascial the trigger points also. Management with dry needling have also shown wonders to some. In 1942, when Dr. Janet Revel published methods of injection into these trigger points, in 1979, Dr. Carol Lewitt with the team members concluded in their study that the effect of these injections were caused by the mechanical stimulation from the needle alone. So there was no need to go for the uh, wet needling. So needle alone can do the same wonders without any kind of procaine or anesthetic material along with the saline. So in 1989, Maryland became the first jurisdiction to allow intramuscular therapy. Then there emerged the dry needling, which is invasive, yet we can say low invasive procedure, but effective, but having several complications also if it is not used with expertise. Like the needle can be penetrated into visceral organs also, lungs, bowel, or the kidney, and may cause further infections. So, whenever these taut band are palpated or elicited with the stimulation, any kind of, or the with the manual palpation only, these respond into a local twitch response, and these twitch response have also been recorded by using the needle with the EMG activity, giving a record of waves like these kind of crest and troughs are formed, and with a persistent crest and troughs, and these waves are formed, which have been seen with this with the activity of needling. Now again we got an idea for using a drug which is forgotten but yet very promising. There's a drug called succinylcholine, which is used as a general anesthetic for intubation, which gives result in 3 to 5 minutes only. It gives persistent contraction followed by the relaxation only. And when we compared the graphs of such needle therapy, dry needling on EMG, and succinylcholine, they give same kind of graphs and recordings after their application. Both have persistent depolarization followed by the persistent relaxation of the muscle fibers. So with this we got an idea why not to use this succinylcholine drug on directly on the myofascial trigger points, but not as a wet needling what Janet travel already done in 1940s. So using this succinylcholine transdermally was a great idea, and we searched for the same, and we got this idea patented also. Now we have sent the results for publication also, and by this year, end of this year or next year, we will get the patent in our hands also. So again, a question was there for superficial muscles. We can just palpate and apply the succinylcholine to get the results within the limited doses which will be decided and prescribed. But what about those deep muscles? What will we do? So I requested my all the team members and my supervisor, who's a hardcore scientist of pharmacology. Then we decided for deeper muscles we can use this drug along with the ultrasound, like succinylcholine with phonophoresis. Then in our team members, Professor Geeta Agarwal is there, who is an expert of formulating such nano formulations. She formulated this drug and by using all the methods, and we did all the studies, and this jelly was prepared in the same gel base which is already being used for ultrasound therapy. So by adding all the antioxidants, preservatives, and chelating agents, all these agents were used in the carbopol gel. Yes, this carbopol gel is the same gel which is used for ultrasound therapy. So carbopol 934 and 940, these both bases were used to see which will be most compatible with the drug. So six type of topical formulations or transdermal gel was formulated by seeing all the six formulations, and which would be found most compatible with the succinylcholine. So carbopol 934 found to be most compatible with the drug by doing all the studies like extrudability, pH measurement, appearance, and viscosity also. So 934 carbopol and succinylcholine gel was formed with the consistency of 25 mg per gram of the drug. So, by getting all the approvals from the ethical committees, we started in vitro permeability studies also. So, permeation studies was done using the cellophane membrane, using the vertical France diffusion cell, and we really got very good results for the permeation of the drug, whether it enters the skin or permeate through the skin or not. And then we started using this drug transdermally on human subjects. 29 subjects with convenient sampling completed the study, and you won't believe, was the only outcome measure for pain was used. And just after the application, by following all the protocols of the using the phonophoresis were followed. Then after giving the ultrasound, after the application of succinylcholine, the VAS score was recorded after 15 minutes, 30 minutes, 2 hours, the very next day, and the third day. So, and all the results were recorded, and the data was analyzed using SPSS software version 20 packages, and the level of significance was used to be as selected as zero point zero 0.05. So the paired sample result between the pre and post intervention after 15 minutes, 30 minutes, 2 hours, the second day and the next day, in all the results p value was found to be zero point 0. So not only quantitatively but qualitatively also, patients reported to us that they are feeling like that they have never kind of this pain ever. So it found to be at we really got this as a boon to us or a physiotherapist. We can prevent every physiotherapist by using extra pressure on thumbs and fingers by using the succinylcholine gel with the phonophoresis technique. So, an immediate effect has been reported after its application. So, it can further be said that if used wisely, yes, after to some extent it is safe, but after that limit or that extent, it is found to be toxic. So, it can be used for treating recurrent spasms or pain of the athletes also. So, it has been found helpful as an effective tool to be used by the physiotherapists. So these are the references. Thank you so much.